Hello everyone, welcome to Patho Excellence and welcome to Histology for Histopathology, a new series built on one simple principle: know a normal to diagnose abnormal. Before we recognize disease, we must understand the normal architecture, function and microscopic anatomy of every organ. So in this journey through the gastrointestinal tract and beyond, we'll learn how normal histology becomes the foundation for understanding pathology. So today we begin with the first organ in our series, the esophagus. In our histopathology, from esophagus we are getting diagnoses like Barrett esophagus, eosinophilic esophagitis, eclasia and carcinoma. So why we should learn normal histology? Because every lesion represents an alteration of normal structure. So what is the blueprint of disease? So if you see normal histology, when there is any adaptive response, there is inflammation, metaplasia, dysplasia and carcinoma. So this single sequence explains most esophageal diseases. So learning objectives of this video is that after this session you should be able to understand fundamentals of embryology, what are the layers of esophageal wall, identify normal histology of esophageal mucosa, recognize all the layers of the mucosa and understand spatial cell populations in the epithelium, explain what is intraepithelial inflammatory cells, interpret past staining in esophagus, recognize normal esophageal cytology and correlate histology with pathology. So, what is normal esophagus? So, it is a long fibromuscular tube that connects the pharynx to stomach. So, grossly its length is 25 centimeter approximately in adults, having 2 to 3 centimeter of diameter and extending from C6 vertebra to T11 vertebral level. And endoscopic landmarks, they use the measurement from the incisor tooth. So, upper esophageal sphincter, which is 15 centimeter from incisors, aortic arch impression 25 centimeter, left main bronchus impression 27 centimeter and G junction it is 40 centimeter from incisors. And primary function of the normal esophagus is to transport food and liquids to the stomach by coordinated peristaltic contraction. So, embryology of esophagus, if we see what is the how the development of esophagus occurs. So, it derives from the foregut and this foregut septation happens at the 3 to 6 weeks, and when the septation occurs, the anterior portion is converted into trachea and posterior is in the esophagus. So, epithelial development timeline shows that at the earlier embryo age, there is stratified columnar epithelium. At the 8 weeks of age, ciliated epithelium appears. 10th week, single layer columnar cells at ends, and at the age of 4 months, there is cardiac type glands development, and at the age of 5 months, stratified squamous epithelium replace this ciliated epithelium. So, what is the importance to know this timeline? Because this squamous replacement begins in the middle third of the esophagus first, but upper esophagus replaced last. And if suppose this embryonic columnar or ciliated epithelium persists, then there is development of inlet patch. So, inlet patch is seen sometimes in some of the biopsies. And fetal upper esophagus initially lacks Muscularis mucosae. So, these are the important points related to embryology. So, if we see muscle and neural development, so neural crest cells migrate at 4 weeks, myotic plexus develop first, circular muscles at the 6-week age, longitudinal muscle at 9 weeks age, and interstitial cells of Kajal appears at week 9, and mature fetal gut appearance is there by week 14. So here in this we can see this is the fetal esophagus histology in late first trimester. So here you can identify this is inner mucosal layer, middle submucosal layer and outer muscle layer, and here you cannot identify muscularis mucosae, and you can here see the vagus nerve. So here in this you can identify this stratified columnar epithelium, and there is lack of muscularis mucosae. This is at the age of late first trimester. So let's see this stain section of fetus esophagus one by one. So here in this you can identify this is the mucosal layer showing epithelium. This is the section from the upper esophagus. So here in upper esophagus you can see this is the muscular propria. So muscularis propria is present, but beneath this epithelium there is another layer called muscularis mucosae which is absent here. This is IHC stain with D240 shows basal layer from the third trimester esophagus, and here this the columnar epithelium is replaced by this mature non-keratinized squamous epithelium. This is the again transverse section from mid esophagus. See, in previous slide we have seen this is the portion from the upper esophagus. Here it is the mid esophagus. So what is the difference? Here you can see mucosa, one another layer of a muscle that is called muscularis mucosae. See, here there is a absence of muscularis mucosae. Here there is a presence of muscularis mucosae in the mid esophagus, and this is outer one is the muscularis propria. And here CD31 stain shows here the section from the mid esophagus, and here you can see anastomosing plexus of capillaries. Now, what are the different developmental anomalies of esophagus? So, first is esophageal atresia because of failure of recanalization, which is most common. Second is congenital stenosis because of incomplete recanalization, and there is key feature is distal fibromuscular narrowing. Third is esophageal duplication cyst. There is split notochordal defect, and here key feature is it is associated with the vertebral anomalies. Another is congenital webs or rings. It is due to incomplete vacuolization, and patient is having dysphagia or may be associated with scleroderma, and this is Scasgi ring. So it is mucosal or submucosal ring and present at the squamocolumnar junction. So here you can see this is the Scasgi ring at the squamocolumnar junction. Here in this, if you see histology, upper surface having squamous epithelium, and in the lower surface there is columnar epithelium, and in between core shows connective tissue, muscularis mucosae, but here the absence of muscularis propria. So typically it is associated with the proximal margin of a hiatal hernia. Now let's see what are the different anatomical levels of esophagus and names of esophagus, and what is the distance from the incisors. So anatomically it is divided into cervical segment, thoracic segment, again divided into upper, middle and lower thoracic segment, and abdominal segment where it is divided into lower and esophagogastric junction. So, approximately upper incisor to G junction, it is around 40 centimeter. So, here in this section pic you can see esophagus, cervical part, thoracic part and abdominal part, which is having association with all the organs surrounding esophagus. Now, when we see barium swell of the normal esophagus, it demonstrates certain normal constriction. So, these are not abnormal. So, you must know that at the region of aortic arch, left main bronchus, atrium and at the diaphragmatic hiatus, it is having normal 4 narrowing of the lumen and having constriction, but it is normal in nature. Now, let us see normal histology and what are the different layers of esophageal wall. So, esophageal shows mucosa, submucosa, muscularis propria and adventitia. Now, mucosa consists of epithelium. Beneath the epithelium there is lamina propria and beneath this muscularis mucosae. So, epithelium, lamina propria and muscularis mucosae, and it is having protective lining function. So, if we see whenever we are getting biopsy, endoscopic biopsy, then only the mucosa part is received. You will not get submucosa most of the time. So, in this biopsy, you have to identify epithelium, lamina propria and muscularis mucosae. So, what is muscularis mucosae? Muscularis mucosae means muscle layer of mucosa. So, here you can see it is beneath the epithelium. So, this layer is muscularis mucosae and the proper layer of muscle means muscularis propria. So, it is in the outer side having 2 layers of muscle, inner circular and outer longitudinal. In between mucosa and muscularis propria there is submucosa. So, submucosa, it contains loose connective tissue, glands and vessels. It contains esophageal glands, also called submucosal glands. So, there are 2 types of glands. One is in mucosa and second is in submucosa. So, we will see in next slides what is the difference between these 2 glands. And last important thing is adventitia. So, this is fibrovascular tissue, but it is esophagus is not having true serosa. So, it lacks distinct serosal covering unlike most GI tract organs. So, what is the clinical significance of this adventitia? Because it is not having serosa, there is easier tumor spread and there is difficult surgical repair after perforation and early mediastinal extension of malignancy because of absence of serosa. So, this is very important point to remember. So, here in this you can see these are the folds of the mucosa which is having outer stratified squamous epithelium. Beneath this there is lamina propria. This is muscularis mucosae. This is submucosa, inner circular and outer longitudinal muscle. So, this is the whole tube section where you can see a lumen surrounded by mucosa, then submucosa and muscularis propria. Now, let us see all the layers one by one in detail. So, mucosa, as we have seen, it is non-keratinizing stratified squamous epithelium. But at the junction with the stomach, or it is called gastroesophageal region, there is a Z line. So, Z line, it transits from squamous lining to columnar lining. Second layer is lamina propria and third is muscularis mucosae. So, this is the section from the mid esophagus. You can identify this is the section of mucosa, contains epithelial lining. This is lamina propria and this pink muscles called muscularis mucosae. So, now stratified squamous epithelium. It is like a skin, but unlike the skin, there is no granular layer and no keratin layer. So, basal layer, in between above the basal layer there is prickle layer and there is superficial layer. So, basal layer is basically small cuboidal blue cells and they are mitotically active cells. Above this there is polygonal cells which are glycogen rich cells, and superficial layer it is flattened mature squamous cells. Now, importance of basal layer is because normal thickness of this basal layer is it occupies 5 to 15% of epithelial thickness, and usually it is 1 to 3 cell layers thick. And distal esophagus sometimes in a distal 3 centimeter normally shows basal hyperplasia more than 15%, and even without reflux symptoms there is presence of this much of hyperplasia. And histologic landmark is that upper extent of basal zone is level where nuclei are separated by distance equal to nuclear diameter. We will see in next slide. Now, stem cell compartment. So, stem cell located in the interpapillary basal layer. So, it is characterized by attachment to basement membrane. There is low proliferative activity, Ki67 negative, and they are having primitive phenotype. And they are having asymmetric cell division, means one daughter cell remains stem cell, other daughter cell migrate upward and differentiate. So, it maintains epithelial renewal. So, let us see, this is interpapillary basal layer and it is in the blue gray color stained cell here. This is epibasal layer. So, it is suprabasal layer, and here it is papillary basal or BBL layer. So, these are proliferative and differentiate into squamous cells, here into orange color squamous cells. Now, this IBL, it is least differentiated stem cells, while this papillary basal layer is more proliferative and this epibasal layer it is mainly differentiating cells. So, normally this is a basal layer containing stem cells. Now, how to identify stem cells in basal layer? So, here this is the IHC stain with MIB1. So, these are all proliferating basal layer cell, but these are the unstained, some of the cells see lacking staining. So, these are unstained cells, they are stem cells, and here you can see same basal layer but having layers of the cell increase in number. So, here this is thicker basal layer compared to here, but both are normal. Now, what is basal cell hyperplasia? Because in GERD or gastroesophageal reflux disease, there is acid injury and it leads to increased proliferation. So, the basal layer which is normally less than 15% of the thickness of the whole mucosal epithelial lining. There is thickened basal zone in GERD, increased Ki67 activity and enhanced regenerative activity. So, histologically you will find basal zone increase more than 15%. So, this is the basal zone. Whenever we see the thickness of this basal zone increase, it suggests any injury to epithelium. So, here is the pus stain in the esophagus. Normally, this basal zone is glycogen poor. So, these cells are pus negative. So, this is the basal layer. So, basal layer is less than 15% of the total epithelial layer. So, here you can easily identify basal layer. Now, suprabasal layer, they are glycogen rich. So, they having pink pus positive cytoplasm, right, and useful in reflux assessment. So, when if patient is having GERD or reflux disease, if you do pus staining, you can identify either increased number of basal cell. So, thickness of basal cell is if increased, you will get this unstained portion increase in size, right. So, basal zone expansion, this basal zone expansion is feature of GERD, reflux esophagitis and chronic injury. Now, ultrastructure, if we see of the epithelium, it resembles non-keratinizing stratified squamous epithelium, and major component you will identify is basal cell, hemidesmosomes, desmosomes, intercellular bridges and membrane bound lysosomal bodies. So, we have seen basal cell, they are cuboidal cells, rest on basement membrane having high NC ratio. They are connected to basement membrane. These are the basal cells. Here they are this is the basement membrane and these are the basal cell. So, they are connected with this basal cell with the help of this hemidesmosome, and mechanical function is mechanical anchoring and epithelial stability. Now, prickle cell. So, it is called stratum spinosum. So, when we see this is basement membrane, these are the basal cells, mostly 3 layers, right, and prickle cell layer which is having a processes. So, this processes you can identify ultrastructurally and it contains desmosome. So, here they are attached with each other with the help of desmosome. So, here you can identify cytoplasmic processes and it creates prickle cell appearance. So, what is the surface maturation of squamous cell? If we see cell shape, basal layer having cuboidal, superficial layer having flattened layer. Nucleus here vesicular, here pycnotic, desmosome, basal cells having numerous, cell process having extensive and superficial having simplified. So, these desmosomes, they are specialized intercellular junction, strong adhesion between epithelial cells. So, what is the importance of desmosome? Whenever there is mechanical trauma or footballer's friction, if there is loss of desmosomal integrity, there will be esophagitis or esophageal sloughing. Now, we have already seen past reaction. So, again revision, basal cells having glycogen poor in nature and they are pus negative, but the prickle and superficial cells are pus positive. And the glandular mucosa of the distal esophagus is typically a cardiac mucosa with variable number of specialized gastric cells and cardiac glands. So, we will discuss in the next slides about these glands. So, now second is lamina propria. So, lamina propria composition is loose connective tissue, capillaries, lymphocytes, occasional plasma cell and antigen presenting cells. Function, immune surveillance and structural support, and it contains esophageal cardiac glands. Muscularis mucosae, it is longitudinal smooth muscle bundles. Function include local mucosal movement and facilitates glandular secretion. It is having thin eosinophilic smooth muscle band. So, what is the distinctive feature? Unlike stomach and intestine, Muscularis mucosae contains only a single layer muscle but no circular layer, right? So, in stomach and intestine there will be two types of layer, but here only the single eosinophilic smooth muscle band without circular layer. So, when we see at the distal or at the J junction there is thickening. So, at that time muscularis mucosae become thickened and prominent, and sometimes in biopsy if distal esophagus biopsy from the distal esophagus is there, because of this thickened normal muscle layer it can mimic muscularis propria. Now, sometimes double muscularis mucosae is seen. So, it is the diagnostic of Barrett esophagus where two layers of muscularis mucosae is visible because of regeneration after ulceration causes duplication. So, characteristic histological feature of Barrett esophagus is duplication of muscularis mucosae. Now, esophageal papillae. So, papillae is nothing but the finger-like projections of this lamina propria into the epithelium. So, this is the lamina propria having a projection into the mucosa, and important point is that this papilla having height up to 50 to 75% only. So, here you can see that upper one third is paired from papilla. So, there is a rule of third. Papillae should not enter this upper one third area of the epithelium, right? And basal cell, rule of third for basal cell is it should not exceed lower one third. So, it should be only in the lower one third, but if they are entering into middle one third, then it is having some pathological correlation like with the GERD, right? So, this is the papillary elongation. So, here you can identify this papilla is entering in the upper one third portion, right? So, this correlates with the increasing reflux severity, chronic epithelial injury, and these are the long papilla and entering into the upper one third, right? So, this is the elongation of lamina propria in the GERD. So, this is microscopic diagnostic point whenever you find this type of elongation of lamina propria papillae in the biopsy. Now, there are many special cell types seen in esophagus mucosa. One is melanocyte. So, 3 to 8% of esophagi may show melanocytes. Clinically importance is It can produce esophageal melanosis or primary esophageal melanoma or rare blue nevi, and mostly located in the basal epithelial layer. So what is esophageal melanosis? It is benign accumulation of melanocytes or pigment. Endoscopically, we can see flat black brown mucosal patch, and differential diagnosis include melanoma, pseudomelanosis and anthracotic pigment. Second cell is Merkel cells. It expresses chromogranin, synaptophysin, CK20 and CAM 5.2 positivity. Rarely seen in concentrated in mid-esophagus, and it is a possible precursor for small cell carcinoma. Now, endocrine cells in esophagus, normally if present, they are earlier argyrophilic cells. It likely represented melanocytes and Merkel cells, and rare pure small cell carcinoma may arise from these Merkel like cells. Now, intraepithelial immune cells. So, intraepithelial mononuclear cells, it includes intraepithelial lymphocytes and antigen presenting cells. So, it is having function of immune defense and antigen presentation, right? Now, intraepithelial lymphocytes, they are CD3 and CD8 positive. Suprabasal region contains these IELs, and they are having small dark nuclei and interdigitating appearance. So, these are the CD3 and CD8 positive T cells, and these are the intraepithelial lymphocytes. Now, squiggle cells. So, squiggle cells are intraepithelial cells, intraepithelial lymphocytes with convoluted nuclei. See, these are the squiggle cells. Because of it is having irregular and elongated convoluted nuclei in appearance, twisted appearance, and can mimic neutrophil, and so that's why it is called squiggles, and this is normal finding in esophagus. So here you can identify these IELs, right, and these are the squiggle cells. Now, dilated intercellular space. So it is the one of the earliest change because of acid disruptions, and results in spongiosis, means there is, you can identify space between these two cells. So it is intercellular space and spongiosis. Sometimes bubble formation is seen in between these cells, and this change seen even before erosion. So it explains non-erosive reflux disease, and histologically most commonly seen in the prickle layer, and it is having this bubble like space. So do not confuse with this perinuclear vacuole. So this is the nucleus and this is the vacuole formation, and cytoplasmic retraction artifact may be sometimes seen. So do not confuse with this, but these are the intercellular dilated spaces. Now, Langerhans cells. So, Langerhans cells, they are antigen presenting cells located in the suprabasal layer, and they are S100 positive, CD1A and CD6 positive. So, let us revise all the cell. Intraepithelial lymphocytes, CD3 and CD8, normal immune cells. Langerhans, CD1A and S100, they are antigen presenting cells. Merkel cells, CK20, neuroendocrine differentiation, and melanocyte S100 melan A and associated with melanosis or melanoma. Now, esophageal cardiac gland or mucosal gland, they are seen in the upper esophageal part as well as GE junction. Characteristic is they are mucous glands and showing pus positive secretions. Function is lubrication and protection against acid, and they are Muc6 positive. Now, what is the significance? Sometimes this cardiac type glands may be mistaken for Barrett mucosa or gastric heterotropia. So, its recognition is important, and its the normal distribution is important because it is located in the lamina propria, and this transition zone vulnerable to GERD, Barrett esophagus, and sometimes adenocarcinoma. So here in this section of mid esophagus, you can identify these are the cardiac type glands located within the lamina propria. So lamina propria is just beneath the mucosa, epithelium, squamous epithelium, just beneath this lamina propria, and it contains all these glands. So these are the cardiac type glands, or this duct lined by gastric foveolar like cells. Now here in this section, this duct is opening into the mucosa. So this pus stain slide shows pus dashed as positive pink material into the duct lining cells. So these are the duct opening into the epithelium. Here in this gland, you can see glands are pus positive, and here Alcian blue is negative. So it is suggestive of that it contains mucin, which is neutral mucin. So pus positive, Alcian blue at pH 2.5 negative. So it contains neutral mucin. So this is differentiating point from submucosal gland, which is containing acidic mucin. So here neutral mucin, in submucosal gland acidic mucin. We will discuss this topic in next slide. So this is again a distal esophagus, proximal esophagus. In distal esophagus, you can identify this cardiac type glands in the lamina propria, and here you can identify this muscularis mucosae is thickened compared to this muscularis mucosae of proximal esophagus. So proximal esophagus having thin muscularis mucosae, while distal esophagus is having thick muscularis mucosae. So whenever we see the biopsy, the location of the biopsy site is important, because if we are getting distal esophageal biopsy, we will have this type of glands increase in number as well as thickened muscularis mucosae, while if we are getting from proximal esophagus, then glands may be there, but the mucosae level is layer is thin compared to distal one. Now if we are getting cytology, so it contains squamous cells, gastric type epithelial cells, oropharyngeal contaminants or food particles. So mostly superficial squamous cell and intermediate squamous cells, and occasionally we can get squamous pulse and parabasal cells. And gastric type cells, if we see in cytology, they are arranged in cohesive sheets having honeycomb pattern, nuclei are uniform, paracentral position, fine chromatin, and small inconspicuous nucleoli. Now let's see submucosa. So this is mucosa which we have already discussed, comprising of epithelial lining, lamina propria and muscularis mucosae. Now this submucosa, which is characteristically shows this submucosal gland and duct of this gland. So let's see submucosa in detail. It is dense irregular connective tissue containing blood vessels, lymphatics, Meissner plexus and esophageal gland, or it is called submucosal gland or esophageal glands proper. So here you can identify large area containing this esophageal glands proper. So it is a characteristic feature of esophagus. It is compound tubuloacinar mucous glands located in submucosa. Distribution throughout esophagus it is seen. While we have seen this cardiac type glands in lamina propria, which is mostly seen in upper as well as at the junction of gastroesophageal junction, and most numerous in upper and lower esophagus. These ducts open onto mucosal surface. And what is the histopathological significance? Sometimes there is retention cyst, chronic inflammation, adenocystic like tumors and mucoepidermoid carcinoma may be seen. So here this is the section from mid esophagus where you can find these submucosal glands just beneath this muscularis mucosae, and there is periductal and periglandular chronic lymphocytic infiltration, which is normal finding, and this gland of this submucosal gland are lined by squamous epithelium, right? So this is duct which lined by squamous epithelium. These are the glands lined by cuboidal epithelium. In the mid esophagus, if we see the component of gland, there is mucus secreting cells with various variable serous components. So these are mucus containing or mucus component of these glands, and some of the gland with abundant pink cytoplasm. These are the serous glands. And here in this section you can see this pars positive, pars diastase positive, pink stain, magenta pink stain, pars positive glands. Alcian blue at pH 2.5. Here it is positive. So it is characteristic of acid mucin. So we have seen lamina propria or cardiac type glands which are having neutral mucin. Here it is having acidic mucin. And sometimes these glands may show oncocytic metaplasia because of some inflammation. So now the normal esophagus contains two types of glands. One is esophageal cardiac glands, which are superficial mucosal glands, and second is esophageal glands proper or submucosal glands. So location lamina propria, here it is submucosa, branch tubular, compound tubuloacinar, mucus secretion in both, distribution upper and lower. Here it entire esophagus shows this gland. Duct having long duct opening to lumen, here short duct. Function lubrication. Histopathological pitfall is it may mimic Barrett mucosa, and it is the source of rare glandular tumor. So remember, cardiac glands present at both the corners, while glands proper is present throughout the esophagus. Now second component of submucosa, where it is Meissner plexus located in submucosa. Function secretory regulation and blood flow regulation, and damage to this Meissner plexus lead to motility disorder. Now third component of esophagus is Muscularis propria or proper muscle layer. So unique feature of esophagus, it contains three regions: upper one third, shows skeletal muscle. Middle one third contain mixed skeletal and smooth muscle, while lower one third contains smooth muscle. So in the upper one third, function is voluntarily swallowing in control by vagus nerve. This is transition zone when both muscles are visible, and smooth muscle is responsible for peristalsis and lower esophageal sphincter function. So this muscle muscularis propria having two layer, inner, these are inner circular layer and outer longitudinal layer. So disease associated with muscularis propria is that whenever there is circular muscle atrophy, there is scleroderma, and when circular muscle hypertrophy is there, there is achalasia. So here in this section you can identify this is the proximal esophagus here, where it shows mixture of smooth and striated muscle bundle. So here in this, smooth muscle are weakly stained, and strongly stained IHC myoglobin antibody shows skeletal muscles. And here these are the strongly stained skeletal muscles with peripherally located nuclei. Third is myenteric plexus. This is located between muscle layers. It contains ganglion cells, nerve fibers, and interstitial cells of Cajal, and it controls peristalsis. So, what is the histological importance of this myenteric plexus? Achalasia, where you find loss of ganglion cells and chronic inflammation. Or in Chagas disease, there is ganglion destruction, and pseudoachalasia, where tumor infiltration lead to this type of effect. Now last layer is serosa and adventitia. So most of the esophagus has no serosa, but it is covered instead by adventitia and facial sheath. So clinical importance of missing serosa is that there are consequences like easy tumor spread, difficult surgical repair, mediastinal extension of tumor, and increased perforation complication. So whenever a patient is having malignancy, even though tumor is having small in size, but whenever there is any spread, if we compare to other site of GI tract, high chances of spread because of its lymphatic drainage. So let's see blood supply, venous and lymphatic drainage of esophagus. So arterial supply, cervical, thoracic and abdominal having different branches. But what is the importance to remember? Because it is having extensive arterial anastomosis, infarction is rare, right? And venous drainage, if we see upper 2/3 and lower 1/3 having uh, different system, and portosystemic anastomosis at the lower esophagus is there. So portal hypertension is there. It causes esophageal varices and massive upper GI bleeding. Lymphatic drainage importance because it is having rich longitudinal lymphatic network. So in mucosa, submucosa, muscularis and adventitia, all the layers having longitudinal lymphatic drainage. So what is the importance? Because of this longitudinal lymphatic, there is skip metastasis and submucosal tumor spread. So making resection margin assessment crucial in esophageal carcinoma. So you have to remember the rule of 3 here. Rich arteries protect the esophagus, portal veins produce varices, and longitudinal lymphatic spread cancer far beyond the visible lesion. So here you can see vessels, arterial supply, and here you can see lymphatic drainage. So this is called longitudinal lymphatic drainage system. So starting from epithelium to lamina propria, submucosa, inner circularis and outer longitudinal to adventitia to thoracic duct. So this longitudinal system is responsible for very early spread of tumor if even in the mucosal layer is only involved by tumor because of its longitudinal spread. So rapid revision, if we see basal cells, key point is hemidesmosome, precursor cells having maximum desmosomes, stem cells they are interbasal layer Ki67 negative cells, gastroesophageal reflux disease shows basal hyperplasia, papilla they are elongated and reaching up to into the upper one third of the epithelial in reflux. Cardiac glands contain neutral mucin, submucosal gland contain acid mucin. Barrett esophagus generally having double muscularis mucosae, muscularis propria having striated and to smooth transition, and serosa is absent. So every esophageal disease begins with the normal structure. So basal cell affected in GERD, stem cells, Barrett esophagus, eosinophils, eosinophilic esophagitis, intraepithelial lymphocytes when there is increased lymphocytic esophagitis, ducts having role in pseudodiverticulosis, circular muscles are associated with scleroderma and eclasia, and absence of serosa and this longitudinal lymphatic drainage is uh, associated with the early tumor spread. So in conclusion, normal esophageal histology forms the basis for understanding GERD, Barrett esophagus, dysplasia, squamous carcinoma and motility disorders. So this is the reference from this book. I have taken this all information, and in next topic we will discuss all the disease like GERD, Barrett's or esophagitis in detail in the topic of diagnostic consideration in esophageal biopsies. So keep watching this channel, and please, if you haven't subscribed this channel yet, please like, share and subscribe this channel for more such series. So thank you very much.